day, my menopausal friends. Here we are again, making your menopausal lives better and better. I'm Menopause Barbie, your menopause tailor, and my, have we talked a lot about osteoporosis. And despite the fact that this is the 27th video in the osteoporosis unit, we are still not finished. In fact, we're just getting to the part of the unit that will help you the most. And that's because everything in the world of osteoporosis is set up in a way that is not in your best interest. That's why I've been so diligent about presenting the material in a manner that is so painstakingly careful. It's because if you're not careful and you don't learn what I'm teaching you, you will experience the pains of osteoporosis and fracture. I can assure you that it will be a lot less painful to just watch my videos in order. So this is video number 222, and it's on the hormonal medication options for preventing and treating osteoporosis. It is critical for every woman to watch this video, and that's because it will be your safety net against osteoporosis and fractures. And it may be the only safety net available anywhere. Now let me take a minute to put what you've already learned into perspective for you. Osteoporosis is bone loss that begins with and is caused by estrogen loss at the time of post-menopause. And although bone loss is rapid and significant, there are no symptoms. The first indication is a fracture of your spine, hip, or wrist that occurs from something that would never cause a fracture under normal circumstances. And the prognosis after a fracture is dire. A DEXA bone density test can tell you if you have lost bone, but all the guidelines designate age 65 for your very first DEXA scan. And by then, you could have already lost a bunch of bone and had a fracture or two. All the lifestyle, dietary, vitamin, mineral, and herbal options for osteoporosis target the disease at the level of prevention or early intervention. None of them can replace bone loss. So you need to know about the options that can replace bone loss. And that's what we'll be embarking on in this and the next 3 videos, which will address hormonal management options, osteoporosis results from the WHI study, non-hormonal medication options, and guidelines for treatment of osteoporosis. In my book, today's material is in chapter 29 in the section entitled Hormonal Medication Options in both the first edition and the second edition. When it comes to the hormonal medication options for preventing and treating osteoporosis, notice that this is the first category of management options that can actually treat osteoporosis. Treating osteoporosis means that the option can do one of 2 things. Either it can prevent bone loss in the first place, which means it inhibits bone breakdown, or it can build new bone, which means it enhances bone buildup. So think in terms of inhibiting breakdown or enhancing buildup, and I'll designate which of those each option does. It's mostly academic because all you really care about is the end result of avoiding bone loss. So the items we'll address today are the following: estrogen, testosterone, progesterone, Tibolone, Teriparatide, and Calcitonin. The first 5 inhibit bone breakdown, or bone loss, and the last one enhances bone buildup, or bone replacement. So I'll address them one by one. And you know me, I'll make a chart of them for you too. So let's start with the most important one first, estrogen. Reflecting all the way back to the very first video on osteoporosis, which was video 196, the very reason we lose bone is because we lose our estrogen. So despite all these other things we consider as management options, do not lose sight of the fact that the real issue is estrogen deficiency, and that's what causes bone deficiency. I hate it when people beat around the bush. Beat around the bush, that's a funny expression, and I'll tell you a story about it a little later. The cold hard fact is that if you didn't lose your estrogen, you wouldn't lose bone, period. So it should be very obvious and logical that taking estrogen would prevent bone loss, and it does. But let's address a few things. All during your reproductive life, you had loads and loads of estrogen surging throughout your entire body. That's why your bones were so nice and dense back then. But at postmenopause, your estrogen drops to nearly zero. That's why you lose so much bone so suddenly. Recall that I've taught you that you lose 2% of your bone each year in the first 5 years without estrogen, and then you continue to lose at least 1% each year after that. If that isn't a perfect indication of your bones hollering for estrogen, I don't know what is. Now, let's parlay that with what I've taught you about the estrogen window of opportunity in videos 80 through 90. The estrogen window of opportunity is the first 5 to 10 years of your postmenopause. It's the time when starting estrogen replacement will prevent bone loss. Oh my goodness! Do you see how the rapid rate of bone loss in the first 5 years of postmenopause is the estrogen window for your bones? Here's a graph of what happens to your estrogen and your bone in those first 5 to 10 years of postmenopause. Here you have estrogen in orange and bone in gray. Along the horizontal axis, you see ages in increments of 10 years starting at age 30 and ending at age 90. Look at what happens to both estrogen and bone between the ages of 50 and 60. They both plummet. Ladies, this is causation. Estrogen loss causes bone loss. It's not just an association or a link, which I taught you about in video number 157. You can't deny that when you lose your estrogen, you lose your bone. Do you see why the estrogen window of opportunity is so very important? If you start taking estrogen in the first 5 years of your postmenopause, you can prevent that drastic loss of 2% of your bone each year. So estrogen is the best possible option for preventing osteoporosis. But the estrogen window of opportunity isn't just about timing. It's also about the kind of estrogen you take. In video 84, you learned that in order to get the benefits of the estrogen window of opportunity, you have to take an estrogen that travels throughout your entire body. That's what your bones are used to. If you use an estrogen that stays confined to your vagina and only treats your vaginal symptoms, you will not prevent bone loss at all. And don't make up your own rules. Whenever I say something like that, someone always asks, well, can vaginal estrogen help at least a little bit? And the answer is no. Do not play with fire. Accept the facts. You can do with the facts whatever you please, but you can't make up your own facts. If you do, you will lose bone. In video 85, I addressed the dosages of estrogen required by the estrogen window of opportunity. You learned that you must take a certain dosage of estrogen to prevent bone loss. Now, this whole estrogen dosage concept is one that women struggle with. They're all worried about taking too much estrogen, but that really doesn't make much sense. Here's why. Take a look at that graph of estrogen and bone gain. bone, your body is used to having very high levels of estrogen. It's like you go from a full tank of gas to an empty one in a flash. But both women and healthcare professionals tend to approach the initiation of HRT by starting with the lowest possible dosage and working their way up. How in the world does it make any sense to start at the lowest possible dosage? Your body was used to great big high dosages. It would really make better sense to start at high dosages and whittle your way down over the years if you so desire. While a very low dosage of estrogen may alleviate your symptoms of menopause, it does not suffice for preventing the bone loss of menopause. And for many women, even the minimal necessary dosage designated by the estrogen window of opportunity doesn't suffice. So when it comes to estrogen as a management option for preventing bone loss, more is better. Here's a chart of the minimal necessary dosages for the estrogen window of opportunity. You've seen it before, but it's much more complete than the ones I've shown you before. Many women actually need higher dosages than these. And then the question becomes, how do you know if you're taking enough estrogen to prevent bone loss? Well, that's where your DEXA bone density test comes in. Remember, there are no symptoms of bone loss, and all the guidelines for bone density testing tell you to wait until you're 65 years old to get your first bone density test. I tell you, no, get it when you first become postmenopausal. Then you can get it every year, 2, 3 years, whatever you want to indicate whether or not you're taking enough estrogen to prevent bone. So here's that T-scale score that I've shown you so many times. If your bone density remains stable, you're taking enough estrogen. If it decreases, you're not. So I'm telling you to use the DEXA bone density test as a tool that gives you information before you lose so much bone that you sustain a fracture. The guidelines are telling you to use it to diagnose bone loss when you're already in fracture land. Don't. Demand it early and pay for it if you have to. It will be one of your most valuable expenditures. And finally, let's talk about estrogen duration. In other words, how long do you need to take estrogen to prevent bone loss? Well, let's look at our graph again. Always go back to basics. The most basic thing I've told you is estrogen loss causes bone loss. So that means that estrogen will only prevent loss while you're taking it. When you stop taking estrogen, you start losing bone. It's that simple. So let's say you take estrogen for 5 years. The timing of your bone loss will be delayed by 5 years. But when you stop the estrogen, you will start losing bone. This is why I have such a problem with the idiotic mantra, take the lowest dosage for the shortest time. Can you imagine hearing that loony mantra with regard to insulin or thyroid hormone replacement? Of course not. A hormone deficiency is a hormone deficiency. You gain the benefits of replacement therapy only while you're taking it. When you stop, all the symptoms and all the diseases associated with that deficiency ensue. So the summary on estrogen as an option for preventing or treating osteoporosis is this. Estrogen is the best option of all because estrogen loss is what causes bone loss. If you start estrogen in the first 5 years of postmenopause, you can prevent bone loss. But you have to use a form of estrogen that travels throughout your entire body. And you have to take an adequate dosage. And it only prevents bone loss while you continue to take it. Okay, the next hormonal medication option for preventing or treating osteoporosis is testosterone. When it comes to bone, testosterone does for men what estrogen does for women. Now, men don't have menopause. They never run out of testosterone. This is why osteoporosis is so much more common in women. But men's testosterone does slowly decrease over the course of their lives, but they just never get to zero. But sometimes a man does lose all his testosterone. This is common with certain types of treatment for prostate or testicular cancers. And in those men, testosterone loss causes bone loss, just like estrogen loss does in women. So testosterone can serve as an option for preventing or treating osteoporosis. But in women, it's only useful for early intervention because the necessary dosages are just too high. The problem with testosterone use by women is all the yucky masculinizing side effects. It causes oily skin, acne, male pattern balding, whiskers on your face, weight gain, and severe aggression. And next, we have progesterone. Now, women tend to make the mistake of thinking that progesterone can substitute for estrogen. It can't. In previous videos, I've impressed upon you the tale of Goldilocks and the Three Bears. It's my effort to help you understand that each of the reproductive hormones really belongs to a different member of the Three Bears family. You know how each of the three bears had his or her own bed, chair, and porridge? Well, that's how the reproductive hormones work. Testosterone belongs to Papa Bear. Estrogen belongs to Mama Bear. And progesterone belongs to Baby Bear. So progesterone isn't for you. It never was. It was in your body to support a pregnancy. That's it. It has nothing to do with preventing bone loss. So don't make the huge mistake of thinking that you can take progesterone instead of estrogen and protect your bones. If you do, you'll be fractured, Mama Bear. Okay, now that does it for the reproductive hormones. Estrogen is absolutely the best thing in the world for your bones. Testosterone would be if it didn't cause masculinizing side effects. And progesterone is of little or no use at all. So now we're going to move on to the non-reproductive hormones, of which there are three: Tibolone, Teriparatide, and Calcitonin. We'll start with Tibolone. Now, Tibolone is actually a synthetic hormone. Very few women take it specifically for purposes of preventing bone loss, but it does prevent bone loss. Tibolone behaves more like a SERM than it does a hormone. And I'll be discussing SERMs in a couple of videos from now. If you've watched all of my videos in order, you'll recall learning about the SERMs in videos 34 and 35. But since Tibolone is actually a synthetic hormone, I'm going to include it here with your hormonal options for preventing or treating osteoporosis. It falls into the realm of intervention more than prevention. Very few women use Tibolone as a first choice. Like all the other options, it has both pros and cons. The pros are that it can alleviate some of your symptoms of menopause. It alleviates hot flashes, forgetfulness, mood swings, and vaginal dryness. A disadvantage is that it is restricted to use for postmenopausal women only. It's not an option for you if you're still perimenopausal or even possibly still perimenopausal. And the side effects of Tibolone are vaginal bleeding and breast pain. Okay, now we're going to turn to two other hormones. These two are parathyroid hormones. First, we'll talk about your parathyroid glands themselves. Your parathyroid glands are 4 tiny glands, each about the size of a grain of rice, that are located on the back of your thyroid gland. So here I have a model of a thyroid gland. It's this orange thing here. Your thyroid gland is this butterfly-shaped gland that sits in your neck right about where your Adam's apple is. And your 4 parathyroid glands are in the wings of the butterfly, all 4 of them. Your parathyroid glands are all about calcium, but they only care about the calcium in your blood, not your bones. And they secrete parathyroid hormone in response to how much calcium you have in your blood. So if you don't have enough calcium in your blood, your parathyroid hormone increases. But the reason it increases is to find a way to increase the calcium in your blood. And guess where it gets the calcium that you need in your blood? From your bones! So be sure to distinguish blood calcium from bone calcium. Your body wants plenty of both, but when your blood calcium is in short supply, parathyroid hormone comes to the rescue. Here's a visual of this process. In the first arrow, there's low blood calcium. So your parathyroid glands produce more parathyroid hormone, which is abbreviated PTH. The high parathyroid hormone steals calcium from your bones, and that satisfies your blood, giving it normal blood calcium. And then your parathyroid hormone goes back to normal. But notice, there's nothing to correct the fact that your bones have been robbed of calcium. So high parathyroid hormone is associated with very weak bones. Think of your parathyroid glands as blood calcium monitors. If there's enough calcium in your blood, all is well. But if there isn't enough calcium in your blood, your parathyroid glands steal it from your bones. It's all about priorities. Your life is more threatened by too little calcium in your blood than it is by too little calcium in your bones. And your parathyroid glands are bone calcium thieves. Now there's another hormone that is the complete opposite of parathyroid hormone. It's called calcitonin. Calcitonin is produced by the parafollicular cells in your thyroid gland. They are also known as C cells. So whereas parathyroid hormone increases your blood calcium level, calcitonin decreases it. So here's a visual again, using calcitonin instead of parathyroid hormone. In the first arrow, there's high blood calcium. So your C cells produce more calcitonin hormone. The high calcitonin leaves the calcium in your bones, and that prevents higher blood calcium, allowing your blood calcium to return to normal. And then your calcitonin level goes back to normal. So a high calcitonin level is associated with strong bones. So you have 2 blood calcium monitors, parathyroid hormone and calcitonin. Well, the last 2 hormonal medication options for osteoporosis consist of the 2 hormones that regulate calcium in your blood. Depending on whether you have too little or too much calcium in your blood, they can help prevent bone loss. The first one is Teriparatide. Teriparatide is parathyroid hormone. Another name for this product is Forteo. It's a pharmaceutical preparation of parathyroid hormone, and it is somewhat counterintuitive in the way it works because normally parathyroid hormone causes bone loss. But in intermittent dosages, it can actually result in building bone rather than causing it to break down. However, this drug is only for women with very severe osteoporosis that has failed to respond to other treatments, or women who have no other alternatives. The results with teriparatide are impressive, with a 50 to 70% reduction in new fractures. But it is a last resort option. It requires a daily injection of 20 micrograms, and it's expensive. Plus, its use is restricted to no more than 2 years. Now, think about this 2-year limit. What do you think happens when you stop taking it after the 2 years? You're starting to connect the dots. Like estrogen, teriparatide is only going to prevent bone loss while you're taking it. This is is a general principle you will see over and over again. Whatever you use to maintain bone health only works while you take it. Don't make the mistake of thinking the effects last longer than that. The benefit of teriparatide wanes rapidly within just 6 to 12 months after stopping it. Most women who use teriparatide switch to another osteoporosis medication when the 2 years is up. And you cannot use teriparatide if you have high blood calcium levels, or if you've had radiation therapy, or if you have had bone cancer. Side effects of teriparatide include leg cramps, dizziness, nausea, headache, and sore throat. And the last hormonal medication option for osteoporosis is calcitonin. Other names for calcitonin include miacalcin and Fortical. Calcitonin is available in injectable and nasal spray forms, and it works by decreasing calcium loss from your bones. So it strengthens your bones, but the results are very underwhelming. Like teriparatide, it is not a first-line option. It's for treatment only, not for prevention of osteoporosis. And it is recommended only for women who are more than 5 years into postmenopause. It can decrease the pain associated with a fracture if you already have one once you started. And the dosage range is between 100 and 400 international units a day. Most women need at least 200 international units a day. Side effects are flushing, runny nose, back pain, nighttime urination, joint pain, nausea, and a rash. So there are multiple hormonal medications for prevention and or treatment of osteoporosis, but they are not even remotely similar in their abilities or purposes. Here's that T-score scale indicating where these hormonal options contribute in terms of prevention, intervention, or fixing. Estrogen is the most important by far. It functions in prevention, intervention, and fixing. If we didn't lose our estrogen, we wouldn't even have osteoporosis. Testosterone is the next best thing. It's good for prevention and early intervention. But notice I didn't even include progesterone because it's worthless. The two hormones that are involved with calcium regulation, teriparatide and calcitonin, are useful only as a last resort for fixing. And Tibolone is somewhere in between for intervention. And here's a little chart of this information. As usual, you can find the chart in the link just below this screen or at my website, which is menopausetailor.me, and you can find the estrogen dosage chart in those same places too. Oh, and I promised I'd tell you the story behind the expression, don't beat around the bush. When I was a resident, we made rounds on all the patients that were in the hospital. It's just like what you see on television. We go from bed to bed and present each patient to the big gathering of doctors. And the most senior resident would usually ask one of the interns to present the patient. One day, the most senior resident asked an intern to present the patient, and the intern started giving all sorts of detailed information that was unnecessary and a waste of time. So the senior resident said, don't beat around the bush. Well, one of the other senior residents was a guy by the name of Tom Nguyen. Nguyen, N-G-U-Y-E-N. He was Vietnamese, and English was his second language. He'd never heard the expression, don't beat around the bush. So he asked, what does that mean? And the other senior resident said, well, it means get to the point. Don't give me all that needless information. So the next day, Tom was the senior resident conducting rounds. And he asked an intern to present the patient. And once again, the intern delved into all the minutiae, and Tom interrupted him by saying, don't run around the bush and beat it. We all just died laughing. If you've ever learned a second language, you know how easy it is to make these kinds of faux pas. And sometimes they're funny, and other times they're just plain embarrassing. Having studied many languages, I know this firsthand. Most of mine are mostly embarrassing. Alrighty, join me next week when I'll present the WHI findings on osteoporosis. It's the stuff you never heard about because the media was shocking you with scary stuff. In the meantime, schedule consultations at menopausetailor.me. Follow me on Facebook, Twitter, and Instagram. Subscribe to this channel, and I'll see you later. Bye!